Okay, so Sharon is an associate professor. She's the head of allergy clinic at the Department of Pediatrics at Tygerberg Hospital, and she's with the Department of Pediatrics at the University of Stellenbosch. She has to stand on a little stool.
Otherwise I can't see the computer. I want to thank Tony very, very much for the invitation. I don't want to thank you for the time constraints. And Jane, thank you for introducing me. So Tony asked me just to try and put something about access to healthcare together in 7 minutes. I talk fast, but we're going to go on a really roller coaster ride here. So I thought, in fact, interestingly enough, Mark Blockman alluded to the fact that nobody really defines what access is. And I found this definition in an article where they said that one needs to, when you talk about access to healthcare, and it was an article relating to access for refugees, that you need to look at the ability to secure a specified set of healthcare services at a specified level of quality, subject to a specified maximum level of personal inconvenience and cost, while in possession of a specified amount of information. So obviously the state has to define, when you look at access, what aspect they're looking at. And the same obviously would apply to people with private health care. So the ethical frameworks, I wasn't aware that Laurie was going to do it, so I'm very glad that she's done this in detail, because I've alluded to very little about the human rights aspect. So the two frameworks that I was going to look at was the justice and distributional ethics framework, and then the human rights framework. And in terms of the justice and distributional ethics, one has to agree on a process framework to make decisions and get support from those affected. And there are a lot of frameworks and suggestions in the literature, and I've chosen one to share with you. But just very briefly to remind you of the 4 principles of medical ethics that were put together by Beecham and Childress in the best-known publication. And obviously in terms of distributional ethics, we're talking about justice, and they define justice as fairness and desert, in other words, giving each his due. So there are 3 kind of obligations of justice. The one would be the rights-based justice, legal justice, both of which we've already alluded to, and then the distributive justice, which refers to fair distribution of limited resources. Norman Daniels, who's written a lot about distributive justice, says that we should ask 3 questions about justice. And the first thing is healthcare special? Is it different from any of the other social goods that society would want? When are healthcare inequalities unjust? And how can we meet competing healthcare needs fairly under reasonable resource constraints? And obviously, if you're a country that's very rich, the way you look at distributional issues would be very different from a country like us, where we do have significant resource constraints. Again, the definition of distributive justice is fair, equitable, and appropriate distribution in society, determined by justified norms that structure the terms of social cooperation. I'm not going to go through all these theories, but just to tell you that there are various theories as to which resources can be distributed, and our healthcare system in the public sector is largely built on the utilitarian one, which is looking at maximizing health for most people. Just to remember that when we talk about healthcare resources, we have to realize that at a macro level, healthcare is part of the social budget, which then also is outside the health budget, then healthcare, and only after that do you have the individual patient within the healthcare budget. And most of us in clinical practice operate at that sort of level where we advocate for individual patients. Some of the criteria that we can use to look at to whom we should allocate scarce medical resources would be, you can either treat people equally, or you can favor the worst off, or you can maximize total benefits, or you can promote and reward social usefulness, so people that are seen as having good character or important people in society. How do we choose between patients? And there are lots of different societal values that have been explored, and I've just mentioned a few here. So you can say needs-based. So somebody who is in need of acute, aggressive, high-tech treatment, should we be putting our resources there? So in other words, somebody that needs renal dialysis, or the example that Haley used. Age-based, pediatricians always say children should get care before adults, but if you really think about it, is that correct? Ethically, morally correct? Opportunity-based, so should you only put your healthcare resources to somebody that you can restore to an autonomous life? But that means that you'd exclude people that are disabled. And then cost-effectiveness-based, which I'm not going to go into. And I just want to share this framework with you of Daniels and Sabin that they called accountability for reasonableness. It's not the only framework out there, but it's one of the ones that the Western Cape government looked at. It's one of the ones that Solly Bennett has written a lot about. And they've called it A4R, which is accountability for reasonableness. And it's undergone various iterations, but essentially it's got 4 components. And the one component is that it must be relevant. So there must be stakeholder engagement, which must be evidence-based and assessed as fair by a group of stakeholders. So it must include patients, healthcare workers, etc. Then it must be out there in the public. It must be transparent and accessible to people. They need to know who we're going to put on a dialysis program, who we're going to offer certain intensive care beds to, etc. There needs to be built in an appeal process where people can revise that. So if you've been refused renal dialysis, you should be able to say, but no, hang on a second, you've assessed me incorrectly and I want to appeal this. And then once the framework has been agreed upon, there needs to be some sort of enforcement with public oversight as well. And then Martin wrote that there should be an additional condition of empowerment, because often decisions in healthcare institutions are made out of a situation of power imbalance, and they may in fact negatively influence the fairness of priority setting. And for example, at our institution, we've been querying, why does pediatrics get so little money compared to some of the other departments? And it must be addressed by the leaders in the institution. You must be able to engage with them, and they have to divorce themselves from that sort of situation. And then the human rights framework, Laurie's given a lot of information. So just to remind you that in terms of the International Covenant on Economic, Social and Cultural Rights, Article 12 states that everyone has the right to the highest attainable standard of physical and mental health. But this convention is mostly focused on social and cultural aspects. And then Article 24 of the Convention on the Rights of the Child says every child has the right to the enjoyment of the highest attainable standard of health and to facilities for the treatment of illness and rehabilitation of health, and doesn't specify whether you have to be a citizen or not. So thank you very much. I would